Right at this moment in time when the NHS is under the spotlight of how human are we as an organisation and empathetic, talking about the notion of NHS productivity, one, it's a welcome change after what we've been talking about for the last few weeks, but actually it's also quite a challenge, although it's not, I have to say, my most challenging ever speech. And I just wanted to share that, get off to a decent start. My most challenging ever speech was I was the rep for Webster's Brewery, trying to sell beer in Barnsley, when I was asked to speak after 3 weeks on the job to the Carlton Village Working Men's Club Pigeon Fanciers annual conference. And I stood up and I said, well, my name's Mike Farrar, I'm the rep from Webster's. I know sweet FA about pigeons, but I have but 2 free barrels of beer behind the bar. I sat down, I got a huge round of applause, and the club secretary said, that's the best speech we've ever had, lad. So after that one, I think I'm playing sailing. But anyway, I can't bribe you today. I need to engage you in some thoughts. And I've got three thoughts in my 15 minutes. The first is really, how do we, what is the public perception of this job that we have at the moment, and how much have we effectively engaged with people about this agenda properly? And I think we're in some difficulty. So on this, so I'm starting with some of the current problems that we face. The first is, in light of the discussions about the health service post the Robert Francis report into Mid-Staffordshire, I think the vacuum created by having the service under pressure, and therefore the absence of a definitive response to the challenges brought by Mid-Staffordshire, and indeed the patients now who very much want to try and help change the service, and I think that's a real opportunity for us. But the challenge is that somehow we've allowed the perception that balancing budgets and quality are polar opposites. And this sense that, you know, if you're a chief exec at the moment and you wrote to Monitor and said, dreadfully sorry, I'm not going to be able to balance my budgets this year because I'm going to put more money into nursing on the wards to ensure patient safety. Please contact me if you've got any problems with that. I mean, that's a kind of bulletproof type of response at the moment, but it's happened because we've somehow allowed this differentiation between managing our money well and achieving quality to be seen as separate and polar opposites, and of course they're not. And the truth is that the vast majority of NHS organisations who manage their money well and actually do manage to redirect it to get better value for every pound they spend, actually are the ones who are likely to be at the end, not always, but likely to be at the end of the upper performance in terms of quality of care. Because the wastefulness of poor quality is huge. So that's something that we will have to address, and there will need to be a counter-narrative to that kind of perception that somehow managing budgets and managing quality are different. They're not, and we can't allow them to be. The second is that if we are going to be able to really make the kind of productivity gains that we need to do on the scale we need to do over the next period of time, you know, and we're probably thinking 10, 15 years, not 3 to 4 years, effectively we have to radically transform the way in which we provide those services. And of course the NHS has always done this. So my journey to work in the morning when I leave home, I drive past Stores Hall Hospital in Huddersfield, which had 1,200 patients at one time in it. It's now a campus for the university. I also drive past Mill Hill Hospital, which was an isolation hospital for dealing with communicable disease, which is now a hospice. I drive past a big lift centre, and I happen to know a parent of one of my daughter's friends who effectively gets home dialysis. Now, all of those things in a 6-mile journey tell you that the NHS is constantly changing because we improve the way in which we can provide services. The problem is that we've got this sense at the moment in the general public that every time we try and talk about this change to services to improve outcomes, get better value, improve their care, actually they think that we are denying them of something. We've got a drift of that story. And just to highlight this, I mean, I can only tell you a personal story of my family. I lost my mum last year. She died just before Easter of vascular dementia. We had fantastic care, fantastic care. She went into a care home in the November preceding. The point I'm making here is that my mum and dad had been married for 60 years and apart for one night. My relationship works on exactly the opposite basis, by the way, but and as do a number of yours, I can tell. The point is, when we had to say to my dad, you know, you've really run out of road. You can't look after my mum now safely and in a way that we could if you could get better care for her. That was a terrible day in our house. You can imagine it would be a difficult day. And what would have kept my mum at home, even perhaps for 2 months extra, were things like low-level continence services, better aids and adaptations around the house, the ability of my dad to understand how to lift her, which we should have given him when he was well himself, because the minute that my mum was ill, he went into crisis and couldn't absorb anything, right? So those simple things, because we got great medical care. And the point is that what he desperately wanted was to keep my mum away from our services. He wanted to keep looking after her for as long as he could. And I tell that story, and so many people afterwards say, that's exactly right, that's what happened in our family. And yet we've somehow allowed my dad not to be marching on the street saying I'm angry because the NHS didn't provide care around us in our home. We've allowed people to march on the streets about how much hospital care we've got. And so we've come disconnected from the public about the story of change that we actually have to make. And the truth is, when you talk about reconfiguration of services, you talk about integration of services, we won't get to places because people are fearful. But if you can tell the stories, people's stories about what makes a difference and what we're trying to do, you help people understand. I've said on many occasions, I do some work in Holland, and they talk about 2 words to describe reconfiguration, changing the location of services: ebb and flow. Ebb and flow. In other words, some things to get the best outcome centralised, some things come away from central services, get commoditised and get made available in people's homes. And many people in this audience, whether you're in local government or you're in a technology industry, you know that some of the things that you could do and want to do are about pulling services more locally into communities. And yet somehow we've allowed the story of change to be about loss of services and about taking services further away. So we've got to change that. So that's the first point I need to make, is that we are battling against an overall story and a narrative made worse last week, I think, by Robert Francis, particularly in terms of public confidence in our ability to communicate some of these things to people. You know, that doesn't give people the understanding of what we need to do. And if you don't have that, your mandate, your permission, the way in which you have to go about this, we will be fighting all the time rather than going with the grain and getting people's support for change. Second thing is, in terms of if we could get our story right about what we need to do to achieve productivity, you've then got to have some real solid processes to be able to deliver it, the mechanics. Almost all the mechanics in the system militate against the kind of things that we need to do. We find it hard to innovate because the scale and procurement challenges make it difficult. We make it very hard for acute hospitals to right size, because when they lose income, they're on the wrong side of monitor or their FT application. We don't put the incentives in the right place to support them doing the right thing. We don't train and redeploy staff to come out of hospitals to work in community settings, because many of our training budgets have been put to one side, and we don't really understand enough about how we deploy our staff anyway to get the best value from them. So those mechanisms in place, and just to give you a sense of this, you know, I think there are 3 or 4 levels, one which we've tried to do really well. So there's the internal to the organisation's efficiency. A lot of people now interested in things like lean and productive work. You know, that's great, but it only takes you so far. There's then the work in terms of pathways between primary, secondary, community, hospital, specialist services, health and social care. You know, that has to happen by people talking. And in a world, we've actually fragmented the commissioning spend when we've put a legal duty on providers to integrate. So somehow people will have to find ways of bringing those budgets together to try to find ways of getting pathways working in a better way. And there's some great challenges in there to the medical profession, because I actually believe that whilst generalist gatekeeping has been a great strength of our system, effectively there are times when access to specialist advice earlier in the pathway would reduce whole lifetime costs of care. But then you get the tribal problems between general practice and specialist medicine in practice in hospital that we need to be brave enough to confront. The third thing is that very often it's not just the relationships between hospitals to community, it's between hospitals. And I've said on many occasions to chief executives in systems that I've worked with, I can think of Greater Manchester, Cumbria, Lancashire and Merseyside, and I've said if you were organising acute care, if you were the chief executive of Greater Manchester Hospitals PLC, would you distribute your services in the way they currently are? And virtually everybody says no, because it's not. We know, but what gets in the way of that is the boundaries between organisations laterally that really have to be tackled. And I think this is the key thing around, you know, what will we need to do? What's in our grasp to really tackle this? If some of the things that people will be exhibiting out there, some of these real opportunities that people have if they're going to be capitalised on, it's fine. If they're going to be capitalised on, then effectively what we need to do is to create better context in which people understand how to make those changes, because otherwise all the efforts are going to be despite the system and therefore less productive than they would be if we could get the system working in the interests of supporting productivity and change. And of course the last bit of the mechanisms is how do we capitalise on the economies of scale? You know, how do we procure, how do we treat the people who supply all those services in the 35 to 40p in every pound that we spend outside the NHS? How do we get them inside the tent on shared risk, shared benefit, such that effectively we can use the opportunities that you have and you know about? And the way in which the commercial sector is viewed with suspicion, and yet we have mutual opportunity, you know, and really the NHS has got to open itself up to understand how to do deals with people who are in SMEs, how to procure better, how to get best opportunity, because we are missing some of the very low-hanging fruit in terms of pulling technology through, pulling productivity opportunity through to help us, because we are worried about the public-private sector boundary and we don't understand how to do risk and gain share agreements. So that's my second point, is that there's a lot of work to do around that, and my organisation needs to tackle a lot of that, because some of that's about mindsets of leadership, some of it's about the policy and the architecture. Last thought for you is really about what is the real productivity agenda. Lots of short-term things that I can see, but I come back to, we're doing some work with the World Economic Forum. World Economic Forum's interested in health, because if you look between now and 3 years out, they come into you and they say, you know, what are you doing to get your I&E balance right? What's your austerity measures? This is where the credit ratings agencies look. But when you look 3 to 30 years, it's all about your spending on health and welfare. What are you doing that effectively gives us confidence that you are aligning your health system to deal with the drivers on demand for healthcare that effectively will drive your expenditure and that growing rate of GDP? Interestingly, they say, and we're doing work in 5 countries, China, which has a lot of money, Spain, Germany, Holland, and ourselves, we're their partner. And they say 3 things are going to happen. 1, big data. As consumers, we will understand more about our healthcare. We will understand more about health and what drives us. We'll lie on an intelligent bed, we'll stand on an intelligent carpet, we'll look in an intelligent mirror, and it will tell us our blood pressure, our predisposition to problems. It will effectively give us more information about ourselves, which we can use to stay healthy. If, driver number 2, we've reorientated our health and social care system to work to support someone to stay well and healthy, as opposed to becoming more and more specialised in dealing with more and more personal knowledge in the way in which our trend's currently going. So how do we change our system to effectively support people, seeing them as assets? Because our biggest opportunity on productivity is seeing people and community as assets, not as needs that we have to deal with. And that mindset is huge. And the last driver that they say, which is incredibly relevant, I think, to today, is that we have to start spending public money against a sense of place, not a sense of function. And so the idea of bringing, and this is huge for health and wellbeing boards and local government in terms of productivity, the way in which we spend education money, housing money, regenerating communities money, health and social care money, has to be seen in the context of how do you spend that to get best value in the round. Because many of our productivity gains are at the boundaries between those sectors and those industries and those budgets. But at the moment we can't get into that because we spend money in our silos. So I hope that that's given you some sense. One is, let me just recap, the big stories. What are we saying to get people on side with the journey that we've got? Secondly, within our organisation, how are we getting processes that go with the grain of productivity rather than making some of these changes harder for ourselves? And lastly, have we really understood the big picture about what we need to do to tackle that 30-year horizon about seeing people and communities as needs, working with them and spending our money in a much more intelligent way? I hope that gives you some frame for the day. Thank you.